I suspect, like you, I've been finding myself really inundated with webinars about COVID, mostly academics talking to academics about really every aspect of the pandemic. In late August, the Harvard Center for AIDS Research hosted a webinar called Black Communities and the Search for COVID Vaccines. And it was the first time, and I have to say about the best example I've seen yet, of giving the community the opportunity to share their perspectives directly and without being diluted. I found that to be a very powerful event. In the 2 months since then, an awful lot has happened. Most notably, the vaccine trials are moving ahead, and the National Academy of Medicine has issued a set of recommendations about how the vaccine should be allocated. Now, although the National Academy of Medicine Committee had a very strong process for gathering input from a wide range of stakeholders, we think it's really critically important that we hear directly from our community here in Massachusetts about how the framework appears from their perspective and what advice they would have for those who will be responsible for vaccine allocation and distribution in Massachusetts. So today we're launching the first of a two-part conversation in which we'll be talking with community leaders. Our next conversation on November 18th will be with the leaders of systems that will be involved in vaccine allocation and distribution, and they will explicitly be asked to respond to our discussion today, in particular how they will integrate the concerns and ideas that come from this session into their plans for vaccine allocation and distribution in Massachusetts. We'll ask people to mute, please. Thank you. I'm thrilled to be starting our discussion today with a brief presentation of the National Academy of Medicine framework by Dr. Ana Diaz-Rue, who's the Dean of the Dornsife School of Public Health and Distinguished University Professor of Epidemiology at Drexel University. Her research focuses on the social determinants of population health and the study of how neighborhoods affect health. She served on the National Academy of Medicine committee that developed the framework for equitable allocation of the COVID vaccine. And in just a minute, we'll have her provide a brief overview. We're then, after Ana's brief overview, we are going to open up for a moderated discussion among our four panelists. I'll get the conversation started, but we'll be taking questions from our listeners in the chat. So throughout Ana's presentation and any of the discussion, please use the chat feature, and we will be trying to get to your questions as quickly as we can. So that's our structure. I'll introduce our panelists after Ana is completed. And with that, I'll turn it over to Dr. Diaz-Rue to get us kicked off. Ana, thank you so much for joining us.
Thank you. Can you see my slides?
Yes.
Okay, great. So it's a pleasure to be with you today. I think this is a great event, and I'll be very interested to hear the discussion and the input from the community representatives and others on the call. So as Karen said, I'm going to give you a quick overview of the committee. This is the committee was charged by the Centers for Disease Control and the National Institutes of Health with developing a set of recommendations, specifically a framework, an overarching framework for vaccine allocation to assist policymakers both in the US and globally in planning for equitable allocation of the vaccine. And the idea is that this framework will inform decisions by other national authorities and local agencies as they think about how they're going to allocate the vaccine. Very briefly, the committee was a very rapid process that happened over August and September. We met numerous times. We had several public meetings. We obtained public input that was incorporated into the draft. And finally, the report came out, I think, a couple of weeks ago now. As a starting point, just to give a little bit of the background that the committee factored in its thinking, certainly the presence of significant racial and ethnic inequities in the impact of COVID-19, which you're all aware of. The recognition that much of the increased risk of COVID-19 in these communities is tied to social and structural factors that have to do with history, with social conditions, with structural racism, et cetera, as well as with pre-existing conditions, which are also linked to these social factors. And also age is a strong risk factor for severe COVID-19. So this is just a little bit of the background, which won't be surprising to you. So the first thing the committee did was identify ethical principles. We spent quite a bit of time on this. So identify some of the overarching ethical principles that we wanted to make sure the framework reflected. The first is the principle of maximum benefit, the obligation to protect and promote the public's health, as well as the socioeconomic well-being in the short and long term. The second is a principle that's called equal concern, which means that every person must be considered and treated as having equal dignity, worth, and value. And last but not least, the principle of mitigation of health inequities. So the need for the framework to explicitly address the higher burden of COVID-19 experienced by certain population groups, this being a moral imperative of any equitable vaccine allocation framework. We also identified 3 procedural principles, 3 things that we need to keep in mind as we implement the vaccine allocation: fairness, impartial decision-making, and even-handed application of the criteria, and especially engaging with populations affected; transparency, being very clear about what we're doing and why we're doing it; and evidence-based, which means basing the framework on the best available and constantly updated scientific information that we have. So keeping those principles in mind, the committee identified an overarching goal, which is to reduce severe morbidity and disease and death, as well as the negative societal impact of the transmission of this virus. And so it identified phases that we would use in the allocation of the vaccine in order to, with the overarching goal that I indicated earlier. And the committee balanced in identifying the phases. We really tried to balance the different population groups, the risk that they have of getting the infection, the risk that they have of having severe disease or dying if they get the infection, the risk of the negative societal impact when they're ill, and the risk of transmitting infections to others. And this was not easy to balance these things as we propose the phases. Basically, after considering these different factors, the committee came up with 4 phases: a first phase that has a jumpstart phase, which focuses on high-risk health workers and first responders, followed by people of all ages with comorbid underlying conditions that put them at significantly higher risk, and older adults living in congregate or overcrowded settings. And we calculated this would be about 15% of the population that would fall into phase 1. Phase 2 expands, and you can see that these are people who are at high risk of getting the infection and who are at high risk of getting really severe disease if they get ill. The second phase, it expands to teachers and school staff and childcare workers, as well as critical workers in high-risk settings, people of all ages with conditions that put them at moderately high risk, people living in homeless shelters or other kinds of group quarters, including prisons, jails, and people who work in those settings, and all older adults not included in phase 1. And so the committee estimated this would be another about 30% of the population. So here you see that we are, the phases start to focus on people, not only those who get severe disease, but also those who are at risk of transmitting the disease to others and who are critical to the functioning of society. Phase 3 includes young adults, children, although we should note that the current trials do not include children, so that's something that will have to be worked out before the vaccine is given to children. Workers in industries and occupations important to the functioning of society and at increased risk of exposure that were not included in the prior phases. And phase 4, everyone else in the United States, regardless of citizenship status, who was not included in any of the previous phases. I want to emphasize that the committee felt strongly that everyone in the US, regardless of their citizenship status, should be included, of course, in whatever phase they correspond to. Now, equity was a cross-cutting consideration. You'll see that the committee tried to capture the reasons why certain groups have higher risk of COVID-19, why we see these inequities through the framework by prioritizing essential workers and critical workers, for example, but also even beyond that, the committee recommended that in each population group, vaccine access should be prioritized for geographic areas identified through some sort of index. One possibility is the CDC's Social Vulnerability Index as an example of a tool that can be used to geographically target the most vulnerable communities within each phase. Just a few words on the equity piece, because it was very important to the committee, the fact that we need to focus on the underlying causes of health inequities that are linked to systemic racism and the social determinants of health, and this idea of applying within phases the vulnerability index to help target particularly vulnerable communities. Very quickly, I just want to talk about a few other things that the committee thought were very important. In terms of how any program should be administered, the fact that federal agencies and CDC need to provide guidance to local, state, territorial, local, and tribal authorities. The fact that all agencies need to work with community-based partners, and so this meeting is great in that regard. This is critical, and also ensure that there are no out-of-pocket costs for the vaccine. And meaningful, effective, authentic engagement as critical to any vaccine delivery system. I'll go through this quickly. This is really about community engagement and communication. The importance of clear, transparent, community engaged communication about the vaccine in partnership with various community groups. The committee also talked about the challenging issue of vaccine acceptance and hesitancy. We know that vaccine hesitancy is common in the US, and there are reasons, understandable reasons why people might be skeptical of a vaccine, and in particular, because of the speed with which the COVID-19 vaccine is being developed, that has raised additional concerns. And so the committee really highlighted the importance of course, ensuring that whatever vaccine we have goes through all the important testing procedures, that we do not rush things or skip steps, but also the importance of a combination of strategies, including engagement of community leaders, the mass media, and healthcare professionals to really communicate effectively about the utility of that vaccine, its safety, etc. One quickly last thing on global considerations, because this was also an important piece of the committee's deliberations, why it's important for us to think globally as well, even as we focus on allocation within the United States. The fact that many international entities are working together, and governments, to ensure equitable allocation globally. And so the committee really recommended that the US engage in these efforts, and in fact, even that the US set aside a proportion of its vaccine to allocate to global efforts and ensure equitable global allocation. So very quickly, to summarize the recommendations, of course, that the framework be adopted, although this is intended to be a framework. It will need to be adapted and will need to be flexible and adapted to local conditions, of course. And there are many uncertainties still about exactly what kind of vaccine we will have, how many doses it will need, et cetera. So adaptation is critical, but the committee hopes that the principles and the overall framework will be useful and adopted. Leverage and expand the use of existing systems. We have very good vaccine distribution systems, and so we should take advantage of those systems and support them and resource them appropriately. Critical that the vaccine be available with no out-of-pocket cost to everyone who is living in the country. Fund and support a vaccine risk communication program and a promotion campaign, and really learn together about the best way to communicate about the vaccine. And support equitable allocation globally. So that's it. I hope this wasn't too fast. I wanted to get a lot in, and you can of course take a look at the report online, and I look forward to the conversation. Thank you for having me. I think you're muted, Karen.
Gosh, I thought I was getting better at that. Sorry about that. That was terrific, and really designed to give our participants and our members just an opportunity to have a little bit of grounding in what the framework looks like. And Becca, perhaps we can put in the chat the overall the URL for the report. I'd now like to bring in our 4 panelists, and I'll just remind you that we are going to be looking to the chat for questions. So if you have specific questions and resources, as I see some being put here, please start feeling free to populate that. So we have 4 panelists today, I'll introduce them in turn with very short bios. We could spend all of our time telling you about their amazing backgrounds. First, I'll introduce Michael Curry, who's the Deputy CEO of the Massachusetts League of Community Health Centers, but only actually is he the Deputy Director until December, when he's going to become the CEO, and we're so excited about that. He has led tremendous efforts to stabilize the 52 health centers that are part of the Mass League, and these clinics that are the backbone of primary care for thousands and thousands of low-income residents in Massachusetts. He previously served as the president of the Boston branch of the NAACP. Lizette Blondette is the executive director of the Massachusetts Association of Community Health Workers. In 1993, she founded the Community Health Education Center and continues to dedicate her professional life to anchoring community health workers as public health professionals. Dr. Tia Martin is the CEO and founder of All Aces Inc. and the co-founder of Next Leadership Development Corporation. She's also a member of the Black Boston COVID-19 Coalition, which is a group of stakeholders and thought leaders from Boston who formed a united effort to demand that decisions, policies, and actions taken and resources committed to the community are effective in terms of stemming the contraction and transmission of COVID-19 and leaving Black residents and Black businesses in a better place post-pandemic. And last but not least, we have Dr. Sarah King, who's the director of Ummah Health, which is a group of over 75 Muslim health professionals who offer various health services, including visitations for hospitalized children and adults, Muslim counseling and referral, and help with health insurance. She's an internist in Cambridge and Roxbury Crossing and a member of the Islamic Society of Boston Cultural Center. So thank you all so much for joining us. We're so lucky to have you here. I want to start off by asking our panelists, and I'm going to ask this question of each person, and then our subsequent questions we may rotate just depending on how our time goes. But I'm going to ask each of the 4 panelists to think about, in terms of meeting the concerns and values held by the communities that you represent, can you comment on 1 or 2 aspects of the framework that you find particularly promising and or particularly concerning? So I'm going to just go in order that I presented you, because that's the order I've got you on my list here. So Michael, I'm going to start with you. Can you speak to that?
Yeah, thank you, Karen. And thank you for this forum and this discussion. We know that there's a lot to focus on in this moment with this pandemic. I'm always on a phone call about testing, tracing, getting patients in for treatment for COVID-19. And getting them back in for the other myriad of issues that people have and getting them back into care. This vaccination conversation has really gained some momentum in the last month and a half. So thank you to the work of the folks that are on this call for making this and elevating the equitable distribution of a vaccine in this conversation. I think, what I'm drawn to most and probably think about the most is the survey polling results that tell us that only half of Americans will even take this vaccination when it's available. And I'm conflicted, Karen. I'm conflicted because I know that the charge that I have representing community health centers, I know the charge that many of us on this call have is to get people ready to take the vaccine. Understanding that Operation Warp Speed gives us no confidence. Using the Star Trek analogy, that vaccines don't typically work that way, right? So from clinical trials and the diversity within those trials to how we communicate around this vaccination as it's rolled out, whether there's efficacy and safety, are all things we're all thinking about, and communities of color are no different. Add on top of the reality that we all face with this vaccine, add on top of that the concern that people of color, and particularly I'll speak to African Americans, have had a very strained relationship with our healthcare system. And you and I have talked about this, Karen, from Marion Sims and the many exploitation of slaves, that we haven't even unwrapped that yet, to and that history. to segregation, Jim Crow, and as I talk about often in a Suffolk class that I teach, the integration of our hospital systems in the 1960s, a historical minute ago. And then it raises the question, how do you convince me to take a vaccine? in an environment where I don't trust systems, where I know that we've not received the same post-Institute of Medicine's unequal treatment, that we didn't get the same care then and now. And I think the report, the strategy of speaking to that is going to be the critical piece. Solve for the efficacy and safety, reassure me, and I'll channel Kamala Harris when I say this, if our president tells me that it's safe, I will not take it. If Fauci and many of the folks on this call tell me it's safe, then I'll know that it's a vaccine that I want to take, and I'll tell others to take it. It's a strange dilemma that we all face, Karen, and for folks like Atia and many of us on the call who represent communities, who speak to communities of color, I haven't even reconciled that myself yet. So I'm glad to see that that's a focus within this work, is how we communicate, what the campaign looks like, and solving for the efficacy, safety, distrust that is baked into this vaccination.
That's really helpful. Thank you, Michael. Lizette, can you speak to the concerns or promising aspects of the framework as you think about the communities you represent? And Lizette, are you on mute?
Yes, hi. I think a very promising aspect of the recommendations of the framework is the inclusion of the social and structural factors that increase risk for my community, our communities of color. A concern is that sometimes these frameworks that derive from science tend to be perceived as black and white. And in the process of translating these frameworks into programs, we lose common sense. So things are taken by absolute face value. Like the, for example, the procedural principle of transparency that calls for to communicate with the public openly, clearly, accurately, and straightforward. A potential disconnect in translating this, in adapting this, adopting this, is that the public is not singular. So I hope that when we get to operationalize and make the fantastic recommendations that have been provided, that the drivers of these plans take inventory of the multiple publics and create and match these publics with appropriate workforces, the workforces that have credibility or not for the right populations. That's the only way that we can effectively reach everyone.
Thank you very much. And you know, your comments really speak to the fact that a very important part in any public health implementation is thinking about history and context. And those publics have very different histories and contexts. And we have to really grapple with that as we roll these things out if we're going to really get to the point where we're having an effective process. Atia, may I ask you to speak to this issue?
Of course. Thank you for having me. Thank you to Becca for being a supporter of the Black Boston COVID-19 Coalition, and congratulations, Mr. Curry, on your new role that's coming up, and thank you to the other panelists for giving context. So what I'll start with is what's promising, right? And the most promising thing is the seemingly increased comfort with incorporating the words like racism and equity in those pieces explicitly in the language. So that is incredibly promising in terms of the principles and kind of some of the other pieces that were highlighted that were important to the group. What I will say is that what we've learned from experts and folks who've been studying racism for a long time and analyzing policy is that when you're not explicit about race and racism, people of color don't get the benefits of policies and approaches. And we've seen that time and time and time again. And so, so when you look at the categories, you know, you can say if you're only thinking of a deficit-based lens, oh yeah, that's people of color, but that's not just people of color, right? There's a disproportionate burden of those issues on people of color, but it's not just people of color. And so when we are saying that, you know, we know that Black people and our Latinx brothers and sisters are disproportionately bearing the burden of this disease across socioeconomic status, then I think there has to be some considerations around what does it actually mean to want to address issues of racism systemically and the systemic nature of racism in terms of how it infects all of us in our roles personally and professionally, but also what it means in terms of how that then impacts people's experiences with the healthcare system trying to get access to the vaccine. And we saw that at the beginning of COVID-19, people going to the hospital, especially Black people going to the hospital and being turned away, even though they had symptoms, even though they were terribly sick and dying. And so that's a reality that is hard to openly and explicitly talk about, but I think now is a time for us to just to explicitly do that because the stakes are high, people are dying, and we're in this next wave where people are disproportionately dying in terms of people of color, especially Black and Latinx folks in our communities. And so if we're going to really kind of peel back these layers, then we have to figure out how are we explicitly going to ensure that Black and Latinx people get the benefits of this, not because they're better than anyone else or more special than anyone else, because the data from a public health approach points us into the direction that that's where the disproportionate burden of this particular disease sits. So I'll just end with there's some resources I recommend to folks to take a look at, because to Michael's point, the distrust in the community is not just based on Tuskegee or kind of these one-off moments that many of us have heard about. There are whole books written on kind of the medical mistreatment, the medical experimentation on Black people explicitly in this country, all the way going back to when we were enslaved, right? And so all the way through to the present. And so for us to just be having these conversations openly and honestly about what that means in this context, that there's a whole historical context of why people don't trust the system, to Michael's point earlier. And then the last thing, I said that was the last thing, but this is really the last thing, I promise. The last thing I'll say is, and I think there's an opportunity, I think we missed an opportunity in this process because of the speed to be able to begin to break down some of those trust issues. When we talk about connecting with communities and keeping them informed, that's the lowest level of engagement. And so if we were doing this on the front end, we would have had community members deeply a part of trials, not just in terms of participants, but in terms of really being a part of the decision-making process and really being partners in terms of helping to make sure folks understood what was happening in the details and having that connection from the beginning, which is really hard when you're going fast. But that's the challenge of living in a democracy, right? That it's messy and it's hard. But it doesn't mean that we don't do those things. So I'll say in that spirit, thank you to Fenway Health, who has been working with the Black boss of COVID-19 in this very different and new way, and being able to talk openly and honestly about building relationships and not just recruiting Black people to participate in things, which is a different approach and requires a different kind of relationship.
Yeah, I really appreciate your points on that. And I think it's really important for us to realize that kind of once again, in COVID vaccines, we've engaged the community at the point that we're ready to go. We haven't engaged them in the process of designing the trials and thinking about them and what are the issues in the trials that are going to be problematic for making sure that we really have equity in the ability to participate. And that is just a problem that we face in our work, and we have got to fix that, in my view. Sarah, can you please give us your thoughts? And you're on mute.
Okay. Yeah, so thanks everyone for being present, and thank you to everyone for doing this work, for putting this together. I'd also like to give thanks to God for bringing us together, and may God bring an effective vaccine and help us to unite to bring it out, roll it out in the best of ways. With respect to the framework, I just wanted to just maybe reemphasize one point that Lisette made, and that was about the data, about being, which I think you guys are all mindful of just being careful about the data, particularly, maybe census data, things like that, but may not paint an accurate picture and may not get you where you need to go. But I would say focusing more on relationships. This is just a beautiful, beginning of things. But I feel like relationships are how you can almost, I envision, water on a piece of litmus paper. It just travels. It doesn't miss anything. It just travels and it hits all the entire thing. And I think that's how relationships are. And I hope that, like a beautiful, colorful tapestry, we can reach everyone. And I think by nourishing these relationships that we're starting here, God willing, we can do that. And I hope that it would create this, tapestry or basket, if you will, that's woven, and it's there, not just for the COVID vaccine, but it's there for other things as well.
Thank you very much. That was a great start for us in the conversation. I'm going to try to weave together some of the comments that have been coming into the chat, and also some things that I think to touch on comments that have been made by the panelists. And this idea about we're seeing these really worrisome signs about people's intentions to take this vaccine. And we're having in a couple of weeks a discussion with people who are going to be actually health system leaders who are going to be responsible for rolling these vaccines out. And so one of the questions becomes, and one of the recommendations being, there should be a communication plan, there should be a community outreach strategy put together. How should we advise those leaders that are going to be rolling it out? What would you like them to hear about what we should be doing to try to help people come to a decision to take the vaccine, beyond Dr. Fauci saying that he's going to do it? I think that will work for some of us, but I think that we really want to think about this idea of, that was in the chat, around trustworthiness. How do we start to build trustworthiness in the vaccine, in the process, and really to ensure that people in our state will be vaccinated? So how do we start to think about that, and does the framework help us address some of those concerns? I'll just open it to the panelists and see who'd like to jump in first. Michael, you're unmuted. Go ahead. Yeah,
I'll pitch in first in that, that is the conversation that's happening in a lot of spaces. And I think that the beginning of this conversation is, and Karen, and you and I have talked about this many times, starts with the trials, right? With these efforts that are underway to come up with a vaccine, and making sure that there's diversity in those trials. We've often had excuses as to why they don't have diversity. And I think we are at a moment in our history where we're now demanding that there be that diversity, and that the people who are sitting at the table to make the decision around who participates and where the resources go should be diverse. And I want to just give a nod to my friends on the call from Mass Public Health Association, the work they did, convening a lot of us around crisis standards of care, right? People make a decision of who lives and dies without diversity at the table. And of course, the outcome of that would have been devastating for Black and Brown folks. So I think there's a need to start on the front end with the diversity at the table. And we've not had that. And I and others and you are on the front end of this conversation with the Harvard Chan School. Then I think there's a need to focus on the truth, And I just got off of a presentation to United Way, and I do these often, where I walk through history from 1619 to 2020, connecting the dots between all those things that Atia talked about, whether it's Marion Sims or Tuskegee syphilis, those sort of episodic events in history, to Institute of Medicine, which validated, which many people of color thought for years, which we weren't being treated the same. And those activists, those militant activists standing on the street corner in Lenny Street housing projects when I were a kid, were actually telling the truth, that they were actually right. And I think the conversation for trust has to start there, a real reckoning with history. And then we work through that to figure out, okay, so what do you need, community, to then trust us as a healthcare community? What do you need to hear from us, see from us? What data needs to be available? And I think that is where we need to start. And then it's, of course, we do a horrible job at large in society about how to reach communities. And I'll pause there to say that the impact of the anti-immigrant policies we have in this country right now should terrify all of us, because as Tina Wright and the folks from the health center community that are on the call know, people were not coming in getting tested because of this anti-immigrant policy. They weren't getting traced because of anti-immigrant policy. They weren't acknowledging to their employers that they had COVID-19 because of this policy, because they didn't want to lose jobs and they needed to take care of their families. We got to solve for all this mess we've created. And solving for that means honesty. It means communication by people who know how to speak to us. And us meaning broadly, whether it's the Latinx community and the diversity within the Latinx community, whether it's Haitian, Cape Verdean, whether it's, name the diversity. And we need to put the resources, put the money where our mouth is. Because if we don't, as we hear with this vaccination, if people don't take it, we don't get the benefit of it. So that communication piece is going to be critical. And I think, this framework and the conversation we've had tonight really makes me optimistic and Karen, I'm going to tell you, I get energized every time I get on the call with you and the rest of the team. Like, I feel amped up that this is actually, people are paying attention. So I think that's where we need to start.
Great. How about other panelists would like to speak to that issue?
I will follow the order. So I would like to make some comments, which I had left for the end, but I love that Michael provided the perfect opportunity for me to speak about the recommendations that we have. So community health workers are not only members of the Black and Brown communities, there are 80% of community health workers are people of color, but they have experienced firsthand the issues that socioeconomic status, immigration status imposes on a lot of our populations. So I think that community health workers need to be front and center in any of these discussions, in any planning effort. In fact, they should be part right now of the planning that DPH is doing. Don't just wait for implementation and call us last minute. Invite us to the table to add some common sense to the discussion. The other thing that I feel strongly about is that the entire community health worker workforce should be mobilized in our vaccination efforts. What I mean by this is that there are about 3,000 community health workers in Massachusetts. They are working for ACOs, health centers, community-based organizations, municipalities. These 3,000 folk are already immersed and credible in the communities that might be hesitant about vaccination the most. Hire them as hourly employees. Do not ask them to quit their jobs to take these temporary jobs. Let them stay where they are and hire them to educate their existing clients and their neighbors about the vaccine. And my third recommendation is to provide them the training that will ensure success. I think it's important for community health workers, as Michael mentioned, to understand the reasons for the hesitancy, the history of medical research exploitation, and what do we know about the people who are saying who are not going to be vaccinated, especially people of color, what are the reasons? Then I think it's important that we get trained on successful sales strategy. How do you sell a product that nobody wants to buy? I mean, how can you be effective at promoting vaccinations, understanding the issues, understanding the constraints, and understanding what's in the psychology of the people that you are trying to sell to? And also provide training on the specific language that will help them answer the many questions that our most vulnerable neighbors have. And lastly, to create a referral protocol that allows community health workers to know that they are not alone. Usually these issues are thrown at community health workers and there is not much backup and they are really not incorporated into the system of care. So as we draft strategies and algorithms and protocols and workflows, make sure that community health workers know where they are and who to call, when, for what.
So the two of you have made some really excellent points about truth, speak the truth. Transparency is something that I think we have not seen a lot of in this space. And I think the transparency aspect is critical, getting the right voices to be part of this and to be leading this, helping make the right decisions. And there were some questions about how we address issues around limited English proficiency communities, and community health workers, I think, are a fabulous way to really try to address that. What are the panelists? Yeah, Atia.
I just want to add one more thing.
Yeah.
And so going back to something I said earlier, which is the focus can't be how do we get people to take the vaccine? The focus has to be how do we build a different relationship with the community? Because if the focus is only on the vaccine, then community members are going to be continue to not trust the system because it feels extractive. It feels like, oh, you just want me to, you know, be the first ones to take this thing, or you just want me to fill in the blank, and it'll fuel more misinformation and rumors and things like that. So for us to reframe this to be about, we recognize that as the healthcare community, that we need to do what Michael said and Lisette said, you know, we need to reframe this whole understanding and own our responsibility as an industry in mistreating people of color in the medical field and doing things that have caused incredible harm. And we also need to figure out how we need to move forward. And a few folks put in the chat, and I apologize that I cannot pronounce the name properly. Is it Lakian Foro? Basically reinforce this idea at some point in the chat that it really is about building the relationship. There is no relationship. It's very broken, which is which is part of a larger problem. And so if we approach it from that way, we're actually swimming upstream to root causes to building these relationships, addressing the realities of our history with racism and how it's impacted real people in their lives, to be able to then move forward. So I'll stop there and just say thank you.
Just to pick up on that idea, I think moving from community outreach, which is what we usually do in these things, to community engagement, which we kind of do okay, or maybe are doing a little bit more now, to real community investment. And I think that's part of what you're saying is you have to have a level of community investment over the long haul that really addresses some of these issues that will help build the transparency and build the trustworthiness over time through these structures. I want to shift to a great comment that Maddie Ribble put in the chat, and ask about the role of local municipal public health officials. And in Massachusetts, we are filthy with local public health departments because of our structure, which is really fabulous when you're trying to think about how you engage communities, local communities in this space, particularly because of the really significant role that local health departments play in vaccination generally. So any thoughts or comments about how we could or should be engaging local health departments?
Maybe a comment on that. So I chair the Health Equity Task Force, the legislatively created Health Equity Task Force and I co-chaired that with some phenomenal members of that task force, and co-chaired with Dr. Sale from Cambridge Health Alliance. At the public hearing that we held, a lot of testimony came up. Many of the folks, even on this call, testified with important information around COVID-19 that we all need to be thinking about, and the urgency of many of the solutions that they offered during that hearing. One of the things that stuck with me, both in the advocacy work I do and from that hearing, was the fragmentation, the under-resourcing of our public health departments. You know, we usually say it in a good sense, Tina, in the health center world, but I'm gonna say it in a negative way. If you've seen one public health department, you've seen one public health department. It's varied, right? And one of the things, and I'll say this on this call, even during the pandemic, one of the things that really stressed out local health centers was how local towns and cities were relying on health centers to respond beyond their patients, because the infrastructure for their local public health departments was so diminished or non-existent that they then relied on their neighborhood health center to sort of stand in and reinforce that work. That's not sustainable. It's not good public health policy. It quite frankly contributes to what we saw play out over the last several months. So vaccinations is an extension of that. That unless we provide the resources, we coordinate this from the state, the federal level to make sure that local cities and towns, town managers and mayors and their commissioners and so forth have what they need. We can't rely on just health centers and others to stand in that way. It's just not smart. And I hear the public health leaders who came before the task force and told us that it's not smart. It's not good public health strategy. It's not a good sound public health response. And we need to figure out what our values are, what our priorities are in this moment we're in. Because, you know, being a historian around the Spanish flu in 1918, the second half of that flu was more devastating than the first half. Most of the deaths came from the fall of 1918. So we have some serious gut check to do around whether we're going to resource and respond to the needs and demands of our local public health departments, or we'll have more sickness and arguably, foreseeably more death than we have now.
Thank you. Other panelists speak to that.
I'll just add that there's this weird trend right now happening at the federal government level, and I feel like it's being repeated, and I can only base it on external observations at the state and local level, which is the devaluing and the discrediting of the expertise of public health experts. And what I mean by that isn't just that we're kind of listening to them, but that they're actually part of the decision-making processes that are happening in terms of how resources are getting distributed, that we're using those public health, the public health model, how it really works, to really move this, to really address the issues that we're facing with COVID-19, but also in any other situation. So I would like to hear more from our public health experts in being out front on these issues, because they're the ones who have historically been bringing up the challenges of all government departments, and at the local or state level, been the ones who have been yelling, hey, racism is a public health issue, racism is a problem. Before we started making declarations, public health was doing that for years. And so I would like to see us dialing back some of the politics, trumping the leadership and voices of our public health experts, and that we hear more from them to reinforce these messages, and we see more partnership at the grassroots level with our public health experts in the community, so that we can also rebuild those relationships and that trust too.
Thank you. Sarah, do you have comments on that issue or thoughts on that issue? In terms of the local boards of health and their engagement and how and where we should bring them in?
Not right now, thank you. I have some general comments, but I'll wait for that.
Okay, thank you. I want to ask, I know I have about 10 more minutes and I'm going to milk every second that I can out of this great discussion. I wanted to cycle back to the fact that the framework had as a real sort of central pillar the idea of addressing social vulnerability and using a mechanism like the Social Vulnerability Index to make decisions about vaccine allocation. And I personally found that to be really, really helpful and wonderful to see. A little bit surprising to see because we don't often put those issues front and center. I'm wondering how the panelists think about that and feel that that will play out in your communities, and how we really set up the vaccine distribution systems to really make sure that if you feel that's the right direction to go in, to make sure that that is actually utilized. Thoughts on that?
I just want to clarify the question.
Yeah.
So is the question about how the vaccine distribution process needs to happen based on the framework, how communities will receive it?
Let me reframe it, because it's not exactly that. And I think I didn't do a good job setting that question up. Sort of, to what extent do you think the Social Vulnerability Index and using that as part of the decision process for how the vaccine is distributed will address community needs and concerns and be perceived as helpful by the communities that you're representing?
You know, I think that going back to the missing the innuendos, I think that these indexes are very helpful, very good, but unless you also incorporate the voice of the communities being served or being targeted, you're going to miss important data, important facts that will help you design interventions that are well-tailored and effective. I just want to mention a brief example of some of the lessons that we have already learned from COVID is the early contact tracing. I mean, in, what is it, April, the state invested a lot of money on creating an intervention, subcontracted organizations to do this. And community health workers, by the way, were totally left out of the equation. The job descriptions for care coordinators, that is the people that would be connecting people impacted by the virus with services. The workers, the job descriptions for those positions called for social workers. Now, they were focusing on skills that they perceived that they needed based on all these fabulous tools that CDC and organizations create. But what they forgot is that, and going back to Sarah's point early on, relationships are critical. It's not just about the skills, which, by the way, community health workers have, but it's also about the relationships that you have with those communities that will make whatever intervention that you're doing effectively. So yeah, the social, the index, the SVI is very good, but you need to add the common sense, the engaging the community, the building relationship with the communities to it for it to be ultimately useful.
Thank you.
And I'll add to that. I think I've often called the pandemic our national Katrina, because if we understood in the Gulf Coast area in New Orleans that the people who are most vulnerable to that natural disaster were those who were food insecure and housing insecure and transportation insecure and had chronic conditions and couldn't shelter in place, didn't have the ability to stock up on food and supplies like other Americans do. There's a lesson in that as we now have a pandemic and we have those same circumstances. They also lived in congested households. And the Social Vulnerability Index is that tool that we should be using to evaluate who are those most at risk based on all those things that we talk about in the social determinants of health context. It is the framework that we should be approaching this as we talk about the distribution of vaccines. But I remember in reference Tina Wright, who's on this call from our team, who says it can't just be all about the index. It has to be informed by people. And that has to be a part of this conversation. We get too into these tools and we don't often go to where people can give us the real data that we need to inform our strategy. Again, I'll give credit to organizations like Mass Health Council and MPHA and others who understand that in a way that many policymakers, well, I shouldn't say policymakers, many of them do, but not enough Americans understand that you can have all the tools in the world, but they're not as effective if you don't involve people in the conversation. And then the next step is that there be diverse perspectives in that conversation. So none of this is a surprise. We now need to figure out who are the most vulnerable and at risk, and that should help inform our strategy.
Thank you.
I'll just quickly add, so number one, I don't represent all Black people, right? Because it's a diverse group of folks. And I think in looking at this through the lens of a diverse group of folks, this is very, like if someone said to me, you know, this is meant to address systemic racism, right? Like this is a key important thing. And then I look at this and I don't see anything about race. Now, what I would translate this into is this is a deficit-based view on who I am as a person, right? So we're all kind of locked up or in homeless shelters or. And so I think so I think because the world is more complicated than that, right? There is a disproportionate burden on people of color in terms of many of these categories. And there's also this reality that just being a Black person who doesn't fall into any of these categories puts you at higher risk when you show up to healthcare infrastructure and all of the realities that come along with it. And similarly for many of our Latinx brothers and sisters. So just as we think about how you translate this into practice, that never gets separated from it because it will get lost because we're uncomfortable with talking about race and racism. And so any opportunity to get out of it, people will opt out of it.
Thank you. Anna, do you want to say anything about how the committee thought about this and what the deliberations were in terms of how you came to this kind of concept? Anything to add on that?
To which concept?
The social vulnerability index and trying to use that as sort of a framing tool.
Yeah, I think the committee really wanted to make sure that we were doing everything we could to ensure that addressing health inequities would be front and center of this effort. And so even after thinking about, you know, making sure that some of the reasons why we see the social and structural and economic reasons why we see these differences across social groups are captured in the framework, there was a sense that we needed something more in addition to that. And so that's why the idea to use the vulnerability index or something like it, not necessarily this particular index, to allow additional targeting would be important. But you know, it's a complicated issue, and I absolutely hear what Atia is saying about, you know, why not include race as one of the criteria, and the committee had a lot of discussions about that.
Yeah, I can imagine.
And to that point.
Thank you. And I'd call your attention to the chat. Monica Valdez-Lupi points out that our health departments, particularly in the state, is not tracking COVID by layering social vulnerability index on that. So this is going to be really challenging potentially as it gets rolled out. And she notes an upcoming webinar that's really looking at this space. So you can see the link there. I know we're out of time, but I'm going to beg you all for 2 more minutes. I'd like to give each of our panelists just 30 to 40 seconds to just sort of sum up, particularly as you're thinking about we're going into in about 2 to 3 weeks, we're going to be having another session with the health systems leaders who are now going to be charged with rolling out the vaccine allocation distribution models. And what are some sort of 1 or 2 take homes that you'd like them to think about? And I can call on you, or you can just jump in.
I can start.
Okay, Sarah, great, thank you.
So just one thought in advertising, just in general, is to give clear, simple stats using billboards, T-ads, just very clear stats about efficacy, risk, and also addressing the immunity question, because I think a lot of people will feel like I had it, I was exposed to it, I'm immune. So just really clear, simple stats. And then, you know, just going back, I agree. I think Atia said it, that as hard as it is, I mean, my background is in medicine and public health, so don't get me wrong, I love the numbers, but as hard as it is, how can we track the numbers of, for example, people immunized, but also not make that necessarily the primary or the only goal, to actually, you know, have those relationships and number outreach, you know, to actually have that be part of the goal. Yeah, and so I hope that, again, as others have pointed out, that the grassroots partnerships can really begin and to be nurtured. And I personally commit to, you know, staying involved with this group, or anybody that would like to form, again, that I hope, God willing, that tapestry that will help everybody who wants to be reached, and not just for this vaccine, but for other goodness too, moving forward.
Thank you.
I'll just that we don't get comfortable with with the simplicity of the index, to some of the points that were made earlier, that we live in an incredibly complex, you know, reality, and that the benefit of engaging and partnering with communities is you get that qualitative information you need to add the context necessary to make the best decisions. And so, and to the point made earlier, you know, things get lost in data, and people need to hear, to folks who are making decisions need to hear this full context, that people are suffering disproportionately in ways that are preventable and unnecessary in COVID-19, but also before there was ever a COVID-19. I also just don't want us to forget that this is peeling the layers back on problems we already had, problems with the healthcare system, problem with relationships, kind of all of these different things. And then just that Ronald Lammy is in the building from the Black Boston COVID-19 Coalition, and a number of other members are on today. And I want to make sure that earlier when I said, you know, that Black people are a diverse community, that includes the Black immigrant community, folks who are immigrants here from Africa, from the Caribbean, from all over. And so as we think about immigrants, that we also think about the diversity of immigrants as well.
Thank you. Lizette, you have any closing comments or suggestions? You're on mute.
Thank you for the discussion. And I think that to reiterate the importance of having community health workers at the table, at every table, and acknowledging that the relationships and credibility that community health workers already have with the very communities that have been disproportionately hit by this pandemic is there. Use it. I mean, I cannot think of a better match for this crisis. And in that process, again, when I was talking about bring on the 3,000 CHWs in the state, use MATRA, use your community, whatever, your professional association, whatever state you're in, as a catalyst or a hub to bring all of these, to recruit these folks and also maybe provide some standardized tailored training.
Thank you, Lizette. Michael, you get to close us out.
The pressure. I think there's a few things. One is I'm encouraged by the focus on partnerships. And I think we often talk about who are the trusted partners in the community that you can go to and work with. And of course, I get to represent 52 trusted partners, 314 practice sites across the Commonwealth, that no matter what insurance you have, what race you are, what gender you are, what your sexual orientation is, you can walk into a health center and get care, and we're trusted for that. But there are other partners. I think about the Black Ministerial Alliance here in Boston. I think about so many people that need to be at the table as we have this conversation. And then the piece that I think is also important, and it was presented today, is we have to eliminate the barriers to getting this vaccination. Cost is always a barrier, as we saw with testing, right? If you want people to get tested, there can't be a cost. It's in our best interest from a public health perspective that you be able to walk up and get a test if you don't have a dime. And the same will be true for vaccinations, and I'm encouraged that that's a core part of this. And then communication. But I'm gonna encourage all of you, particularly all of you who are white males and females on this call, that if you look around a table in any conversation and there's no diversity, I need you to be upset. And I need you to decide to be allies in this work of making sure that there's diversity in every part of this conversation. Otherwise, this is all for naught. And if we don't take the vaccine, it'll be because there wasn't the right strategy and the right approach.
That was a terrific closing point, Michael. Thank you very much. And I just thank so much our speakers today, Anna, Michael, Lizette, Sarah, and Atia. Thank you so much for taking the time to be part of this. And to all of you who joined us, we're very grateful for your ideas. The chat has been blowing up here. I've been doing my best to pull in the ideas, but we will capture that and we'll be posting this on our website. We'll send out information about that. Becca, do you want to put up the, or tell people about the next session?
There you go.
Yeah, go ahead.
I got it. So I put a link in the chat, but there will be a next session sponsored by the BU, our partners at BU. You can sign up right now because you're so excited about how this conversation went today. It's going to keep going. And as Karen mentioned earlier on, this will be a conversation with leaders who will be closer to the kind of distribution mechanisms, really the advice from today. Hopefully we'll be able to work into those questions in that conversation. So we really encourage you to join us for that second part of the conversation.
Thank you so much, everybody. And thanks for hanging in there with us a little bit longer. Have a great night.